Hey, thanks, folks, and welcome to Georgia MemoryNet Insights. Uh, we are recording, so thanks for Dr. Jennings, to your permission for recording. Excited to have our discussion today. We're really pleased to have Dr. Lee Jennings from the University of Oklahoma join us today. I put in an intro into the chat, but I wanted to say a couple more things. She is smart, she is innovative, she is accomplished, she is caring, she is driven, and additionally, she's friendly and funny. So I know we're going to have a good time today. She's a go-to person in the United States for how to care for patients with ADRD. She is a national leader as well as an important leader and clinician in Oklahoma. And we're so glad to have you here. So Dr. Jennings, feel free to kick us off.
Well, thank you, Ted, for that really warm welcome. It is really a delight to be here today with you guys. Excited to get to talk with you a little bit about care of persons living with dementia. I'm a primary care doctor, a geriatrician, and when I was preparing this talk, I really wanted it to be useful to primary care providers who may be taking care of people with cognitive impairment and dementia. And so I hope today that I can use some cases from my real practice to kind of illustrate some tools that I have found particularly helpful, and hopefully it will be useful to you guys as well. And I want to acknowledge our Oklahoma Dementia Care Network. That is our HRSA-funded geriatric workforce enhancement program that we have at Oklahoma that does support a lot of our community outreach and work with people living with dementia and their family caregivers. So get going here.
And go ahead and switch your display settings so we can see.
Oh, is it not? It's not showing the correct display for you guys?
Yeah, it's showing your view of the presentation. You're in the right place. Just go ahead and pull that down. Ta-da!
Like that? Okay. Okay. Great. All right. Well, that's great.
Try that one more time. So sorry.
That's okay. How about now?
Not. Yeah, it was working before.
Why don't I stop share and we'll just start over? How about that?
Sounds great.
Okay. So let me just try it again. We tried this. This is the third time's a charm.
I know. We did this. We did this twice successfully before.
All right. So let's go from the beginning. And then does that look correct now?
No. Yes.
Yeah, we're good. Okay.
Back to you.
All right.
Thanks.
Outstanding. Okay, great. Okay. So I have no disclosures related to this presentation today. And we're going to try to do some poll everywhere. So Ted gave me a little tutorial on how to do this, and I read the directions, and I'm hoping it works. So if you guys would take your smartphones out and use your camera there to click on that QR code, there should be 3 poll questions, and you'll see them as we get to them in the presentation. I'll give you guys just a moment to pull that up. And then if you miss it, there should have a little QR code on every question as well. So here's our first case. So this is case number 1 is I can't sleep. So 78-year-old female presents for a new patient appointment to establish geriatric primary care. And her primary concern is really that she's having this ongoing insomnia. And on review of kind of her meds, it looks like she's taking zolpidem, extended release, 12.5 milligrams a night. And on history, she's been on some combination of zolpidem, temazepam, or alprazolam for about the last 25 years. Her sleep is still really not great, and she and her husband are really resistant to, coming off of or stopping that zolpidem. And in fact, they'd like to know if there's anything else that you could help prescribe for the sleep. And you go through the meds again, doing a good, thoughtful med review. And she's also taking tramadol, duloxetine, and baclofen for chronic neck pain. And you ask her kind of like, how's that working for you? Is it helping? And she says, she thinks it helps some, but she still has pain on most days that affects kind of her function and range of motion. She denies any kind of upper extremity weakness or numbness. And when you're talking to her, she really appears to have some short-term memory deficits. She can't quite remember what medication she takes and when she saw who she sees for the pain and who prescribes things. And you notice some mild word finding difficulties and some circumlocutions where she kind of talks around what she's trying to describe instead of using the correct word. And she kind of defers questions frequently to her husband. So you'll ask a question and she says, well, honey, and he answers it for her. I decided in this visit, like, I need to figure out this patient's cognitive status a little bit more. So I decided to do a Montreal cognitive assessment, or a MoCA, and her score is 12. And to give you a sense, That's on the moderate dementia, moderate to more advanced dementia side. So that's concerning. So I'm definitely abnormal. And my first poll question for you guys is, what do you want to do next? So here we are. Okay, so these are our kind of answers. So go ahead, I'll give people a moment to answer in real time here. So I can't see the number of responses, but things are kind of changing here. So looks like we've got some people that say maybe some CBT, taper off one of the pain meds, taper off the zolpidem. Nobody's ready to refer her for neuropsych testing or an MRI. Okay, so I'm going to go on. All right, so kind of a third,
It's a
third, and
three-way
third. Okay,
tie.
that's good. That's a good question, right? And the truth is, right, there's no perfect answer here, right? I'll tell you kind of what I did and why I did it. And what I decided to do was actually focus on coming off of that sleeping pill first. And the reason is that there's pretty good data now that these medications are probably more harmful than they are beneficial for sleep. So there's been some studies. So the text here is from a case control study that was in BMJ back in 2014, a little bit older study now, that looked at case control. So they took people with dementia and then looked back to see if they'd ever had benzos or Z drugs. And basically, every use of a benzo or a Z drug increased your odds to 1.5 compared to those who hadn't used that drug of developing dementia. And the longer you used it, the greater the risk, right? So if you used it for 3 to 6 months, your odds ratio is 1.3. And then if you used it for 6 months or longer, which would have definitely been this patient, your odds went up to 1.8. So, and then this is a really nice infographic from this is actually from the Canadian Deprescribing Network. So there's a US Deprescribing Network and a Canadian Deprescribing Network, and they're both great. Majority of the tools I'm going to show you today are from the Canadian Deprescribing Network because they have a lot of very developed patient resources. But this is an infographic that kind of outlines the benefits versus the harms, right? So, if you take one of these medications, you get on average, about 35 minutes more of sleep, and you go to bed about 15 minutes faster. But the trade-off is that 1 in 6 people have some kind of harm, and that includes this impaired cognition. And also because it's a sedating medication that acts on the brain, so it increases your risk of falls and thus fractures. And it's like being intoxicated when you drive, right? So obviously impacts ability to operate a motor vehicle if you wake up foggy and groggy the next morning. And so these are some of the references you're interested. So this is where I kind of decided to focus my efforts initially. And what's nice also about the Deprescribing Network is that there's really good tools to help you do this. And this is one of those tools that for me was practice changing. So I use this pretty regularly and I've had a fair amount of success in using these different tools for deprescribing. This is the one for sedative and hypnotic medications. And as you can see, it goes through kind of the list of them. So you can be like, hey, look, your medication's on this list. This isn't just me telling you, this is an organization that has created materials to help people who are on these medications come off of them. And then, Z drugs and benzos are not the only medication that's high risk for cognition. So they have some other ones as well. They have them for gabapentin. They have them for opiates and chronic pain. They actually also have them for antipsychotics. So I have found these to be really, really helpful. And as you walk through it, all of them kind of have this similar format where they go through a quiz. So it's sort of like, what perceptions does the individual come with, or the caregiver come with, right? Because a lot of times it's people with dementia, this is for the caregiver to help them understand the risk as well. And then it goes through kind of the answers to these true false questions with accurate information. And then what's also helpful is it has information about what are you going to do when you come off of this medication, your sleep is worse, right? In the near term, what are some ways to help you sleep? What are some other ways to help you deal with anxiety and stress? And it's in that one brochure. And all of these are made to be patient facing so that they are written, not for a clinician, but for an individual with the problem or a caregiver. So, but one of the things I always, when I teach and I ask, our fellows we work with is so you can decide to taper, you've given the individual the information. How long do you taper for? What's your plan there? So you guys can pull this one in. Are you guys seeing, I'm not seeing responses. Are people participating? Is it working? There it goes. Okay, great. Okay, great.
I think that delay was thinking.
Okay, and that's fair. That's good. That's good.
People were thinking about their answer, including me.
What do people think? Okay, so we got about a month, a little over a month. Some people want to go longer, 4 months. Nobody wants to go 2 weeks. People good? Okay, all right. We'll keep going. And I am not seeing the chat. Are you following the chat? I see that there are some chat comments there. I don't know if that's something we should address now or come back to.
A lot of them are me providing information from your slides and easy links, and so I'll make sure and interrupt you when it's timely, and then I'll roll them up at the end.
We kind of got a majority say, okay, about 4 weeks. So this was another thing that I'd say for me was practice changing. So in these tools, it's really about a 4-month taper. So, what's nice about these handouts is that there is a tapering off that the individual can do on their own on the back page. So what I often will do is talk through it and then talk through the taper with them. And it actually, because it goes from a full dose to a half dose to a quarter dose. So they can take their current prescription that they have. And as long as they have tablets, and have a pill cutter, and they're not teeny tiny where you're just flaking off bits, right? We've all seen that. Then they can actually do this on home. The one where I will say it does not work is temazepam, because temazepam is a capsule. So just FYI, that is one where you have to then order the lower dose. But it's really nice and it goes really slow. And so what I've done with individuals when I have done this is say, hey, let's work through the first 4 weeks and then let me see you back. And let's talk through how it's going. And let's revisit those behavioral interventions that how are those going? Are you, how is avoiding daytime napping going? Have you, have you been able to get a regular routine time to go to bed and get up every day? Those kinds of things. And I think in the guidance on this, it is okay to take a break on tapering, but don't go backwards. And I think that was really good advice in the sense that, I also remember, like, if I get them on a lower dose, like if I got her down from 12.5 to 6.5 or 5, right? That's harm reduction, right? I'm in a better place than I was if I left her at 12.5. So even if I can't get her off, getting her a lower dose is beneficial. And so this is where I think this is really helpful in bringing people back kind of partway through and seeing how the taper is going. But this is a taper, if you see, so 16 weeks, so like the last 2 weeks you're off altogether, is about 4 months. I think acknowledging that sleep will worsen in the short term helps validate people's experiences with this and prepare for it. Adding cognitive behavioral therapy to the slow taper did improve cessation rates. So CBT for insomnia is the best therapy, right, with the best data. What I run into a lot with patients with cognitive impairment is that it's hard for them to participate. Sometimes they'll go with the caregiver, and the caregiver is really learning about the strategies too to help the patient. And so I think that can be valuable. But they've got to be engaged to do that. But, we often will add like, oh, I have melatonin, and actually did not help with cessation, just FYI. I think melatonin works well for some people and doesn't work for others at all. So it kind of depends. And then obviously discussing the risk of cognitive impairment and falls and then dependence, which is kind of what that patient handout does. So I found this to be really useful. I've used it a lot in my own practice, just even to get dose reduction if we don't get all the way off the med for the individual. And then if you're interested, this is a very nice Canadian, in the Canadian Family Medicine Journal, that goes through kind of the guideline around this and the evidence that backs up these tools for benzos. Okay, so what happened to this individual? So what happened next? So we actually got her off the zolpidem altogether, but it took us 9 months. We did it really slowly. We just kept kind of working on it every time I would see her. And then her husband actually got on board because he felt like she was brighter. He felt like her cognition improved and her mood improved. And we repeated her MOCA, and she actually had a 4-point improvement in her MOCA to 16. So she still had underlying cognitive impairment. It did not get rid of what ended up being Alzheimer's disease, but we did see some improvement. They were not all that into CBT. She was not interested in going. He didn't want to drag her to the visits. We did not go ahead and do that. I did give him lots of information. Most of it he didn't really enact, to be truthful, but I really think it helped with expectations, and I think it helped with him realizing kind of some of the harms about the sleeping medications. With regard to her pain, after we kind of simultaneously, while we started working on this, we started working on the pain. We actually sent her to an anesthesiology, pain medication, pain management that we have in our health system. She got a local injection, and then slowly we then worked on getting off the tramadol and the baclofen also over months. And then we sent her for neuropsych testing and MRI after we'd gotten her off the sedating medication, so we could sort of get a clearer picture of what her underlying cognition probably looked like. So that was that case. And then I'm happy to take questions at the end, and I'm that may be the best way to do it. But if there are questions, you can chat them, or I can stop and answer them as well. All right, so that's our first case. Our next case is, what did you say, Doc? And so this was an 82-year-old gentleman with early stage vascular dementia that came to see me for follow-up. We had known he had a diagnosis. His MoCA was about 18, 6 months prior. He had become a little bit more irritable with family members, kind of frustrated. He had an outside kind of workshop he called the pole barn, and he would go out there basically to get away from the family. And he was doing it more often, and the family was like, maybe he's depressed. But when you talk to him, he's like, I'm not depressed. I like going out. I still have, I like to work on I go out there and, work on furniture, and I have activities I like to do. His PHQ-9 was normal. And he was like, you know what, the house is too loud, it's too chaotic, and I just need to get out there sometimes. And when I was talking to him, it became clear he was, having hearing difficulty. On the interview, we did a whisper test. He could not identify the numbers and letters pattern on the whisper test. And we talked about, hey, do you want to get some hearing aids? Do you want to see an audiologist? And he said, they're really expensive. Like, my friend, went to the audiologist, and they're several $1,000s. And I'm not going to pay that. And I'm not really even sure that, I would wear them and need them. Right. So that was this case. So, this is another area, I feel like the connection between hearing loss and cognition that has been more visible in the literature as of late. There was a Lancet review in 2020 that looked at modifiable risk factors for dementia. And what was striking about this to me was that early education, so this is primary and secondary education, and treatment of hearing loss in midlife were the two largest modifiable risk factors for dementia. And again, this is one of those things that for me has been kind of practice changing, and that I've been paying a lot more attention to hearing loss in my patients with cognitive impairment, but also in my older adults without cognitive impairment because of these data. To get into a little bit more of the more recent studies, there was a study in JAMA Neurology in February of this year. It was a systematic review meta-analysis. They actually had two different meta-analyses in there. The first one was of 8 different studies with almost 127,000 participants who had hearing loss, who did not have cognitive impairment, and they were followed anywhere between 2 and 25 years. And what they saw was that people who used hearing aids had a lower hazard of cognitive decline of about 19%, so hazard ratio of 0.81. So using hearing aids actually kind of delayed their time to event for their having cognitive impairment that was detected, which is, when you talk to people, that matters to them, right? If they can, if they're likely to develop dementia in their lifetime, if we can delay the onset of that by treating hearing loss, that's pretty impressive. And then another meta-analysis of 11 studies, smaller number of participants that had cognitive test scores in some of these studies, and they saw a small improvement in cognitive test scores for people using hearing aids. I don't want to imply that getting hearing aids reverses Alzheimer's disease. We know that's not true. But if you have, we also know that it's a threshold disease, right? So if we can do things like education and treating hearing loss earlier in life, to kind of maybe increase that time to threshold to where people begin to have impairment in functional activities, that's meaningful. So that's another one where, kind of practice changing. Can I identify cognitive or hearing loss to then encourage people. But, right, what's the barrier to hearing aids? They're really expensive. Really expensive. And they're not easy to use either, right? So sometimes I feel like patients will say, I got these multiple $1,000 devices that I hate, So I just think and there's been a lot more advance in kind of what's over the counter available. And so I think that's one of the areas I've been trying to become more educated in as a primary care provider, so I can present options to patients. And so this was a stat that came out of a Cochrane review, which I don't have on here, so I can send that to you, Ted, where 6 of 7 older adults 50 plus don't use a hearing aid. 6 out of 7. So the vast majority, right? They know that somebody has told them they have hearing loss, and they still don't have any kind of amplification. So this was a slide that came out of AGS where they highlighted an article. Give Eric Guadera credit for this, but this kind of goes through prescription hearing aids, right? These are somewhere between $3,000, $5,000, $6,000, right, depending on the model. FDA approved, purchased by an audiologist. They're fit, they're fine-tuned, right? Over-the-counter hearing aids kind of look like AirPods, right? A lot of the models, they are FDA cleared. They're purchased directly by the consumer, and you have to self-tune them, but you do have to have a smartphone, right? So people have to be technologically inclined enough to have a smartphone and have enough money. There's a very nice article by the National Council on Aging I reference here, that goes through, I think, like the top 9 or 10 over-the-counter hearing aids. And there's still I think the cheapest model I saw was like $199 all the way up to like $3,000 price point. So still fairly expensive. And then there's personal sound amplification products, right? So these are ones I actually have in my clinic. I have in my doctor's bag for home visits. It's $60 on Amazon. This is one model. There are others. Obviously, can't be tuned to the individual. These are old Walkman style headphones. It's visible on the outside of the individual, that they've got hearing loss or walking around with this on. So not everybody loves these, but it is a more affordable option. And there was a really cool study that was done out of Baltimore in 13 different community sites in Baltimore. It's called the HEARS trial, or Hearing Health Equity Through Accessible Research and Solutions trial, published in December of 2022. They looked at 151 older adults with hearing loss, and the majority of these participants reported an annual income of less than $25,000. 45% did not own a smartphone. So these are participants for whom the first two options are really not feasible, right? These are, so what they did, the intervention was to provide one of those kind of pocket talker like amplifiers, plus a 2-hour session with a community health worker on how to use it compared to waitlist control. And the outcome was this hearing handicapped inventory for the elderly survey that looked at communication difficulty. So if your score went down, you reported less communication difficulty. 91% of the people in this study completed the intervention and reported that they were still using amplification for at least an hour a day 3 months later. So one of the other things that's been really challenging, right, is that people get these aids and then they don't use them consistently, right? So this is a low cost intervention. Most people were still using it. And they reported a 13-point decrease, so improvement in their score, with really no change in the control group. And if you look at studies in that Cochrane review, that's similar magnitude for what hearing aid studies report with regard to improvement in communication. So these are not perfect. They're not, if people can afford hearing aids and want to get them, I encourage them to do so. But I've been more making sure make patients know that these are available on Amazon, that they're reasonably affordable, and that they do improve communication. So what happened with my patient? He opted to buy one of those for himself on Amazon. He really likes it. He uses it at church. So he sits in the front pew, turns it all the way up, puts his headphones on, and he can hear better. He uses it one-on-one with his family members, talking to his grandkids, and on our visits. He still does not like the large group events. He does not like to go out to eat. He still goes out to the pole barn when everybody comes over to his house. He's not perfect, but he's pretty happy with it. And his wife says that she likes it as well, because it improves her communication with him. And then it's also, the whole intervention has made the family more aware of his hearing loss, so that they have adapted how they're interacting as well, which I think has made a big difference. His repeat MOCA was still 18. We did it a year later, really not worse. So who knows if it's really impacting that or not. We may be kind of beyond that, but I think there's a quality of life improvement for him. So that felt positive.
Hey, Dr. Jennings, you've got one more really interesting case, but maybe if we give a 15-second pause to see if anybody wants to put in any questions about anything that's come up so far. Lots of good quality of life outcomes for this last patient that you described. Why don't you hit the last one? I think we're in good shape.
Okay, so last one is Cass cases. I'm a good driver. So 85-year-old man, early stage Alzheimer's and vascular dementia. He actually had neuropsych testing already, an MRI of the brain. His MoCA was 22 a year ago. He was a retired dentist, still lived independently. His son was his primary family support. Son did a lot of IADLs for him. So they moved all of his finances over to automatic bill pay, added the son to the account. Son, kind of picked up his groceries and sundries when he did his own weekly shopping. They'd hired a housekeeper. Son came over once a week and filled the pill organizer, those types of things. He was frail overall, frail looking guy, had recurrent falls. I had gotten him to agree to use a rollator walker, and he had some improvement with his gait and mobility with that. He had some cardiac history with chronic AFib on apixaban and had a pacemaker placed for probably tachybrady syndrome. Had some heart failure that was well controlled, CKD stage 3, and some NEOA. When kind of asking about his driving history, he'd had no accidents or tickets. He denied any near misses. His son kind of agreed that he wasn't overly concerned about the driving. There were no, dents or dings on the car that were unexplained. He was still driving to Walmart. There was a neighborhood Walmart. He liked to be able to go there and get whatever he wanted when he wanted it. He had kind of begun to self-restrict his driving. So he was not driving at night. He did not drive to the highway. His son always brought him to the visits with me. And so kind of the question at that visit was, we kind of got into this, well, is he safe to drive? And, how do I assess that? So that's kind of my question for you. Next poll question, is he safe? The first option, no. He's frail, he's falling, he has dementia, this is a safety issue. Second option, yes. His MoCA is in the MCI range. He hasn't had difficulty with driving. There's really no reason to limit his driving at this point. Or I'm not sure and I want more information. But here's the caveat. 100% of people pick that. We got to see some chats. What other information do you want? You're the doctor. You got to make the call on this. What do you want to know that you don't know yet? What are you going to assess? So I think I do need to click on the chat here. See this? Let's see a clock and some trail making. Okay, I like it, Carolyn. I'm with you on that. Roadside test. Okay. Send them to the
maybe even simulator test.
Yeah. OT, a driving evaluation. What are you gonna? Let me just push you guys a little bit more. Okay, we have one driving simulator and OT in our area, and they're booked out for 4 months. What are you gonna do in your visit? Driving HPI. Okay, so I had the same thoughts and questions, so I looked it up. So I said the same thing you did. I said, I am not 100% sure. I'm a little nervous. His gait is kind of impaired. He's frail. I don't see a lot of driving stuff. His MoCA is 23. I will tell you on the MoCA, a year ago, he had trouble he did the trails. He had trouble with the cube. He got the circle and the numbers on the clock, but put the hands in the wrong place. Not terrible, but like reversed them. And he had difficulty with the delayed recall. He did get, I think, a couple of them back. He didn't get the points back, but he got them on queuing. And I think he called the rhinoceros a hippo. So not, we've all seen that, right? Like smattering of problems consistent with the diagnosis, early stage. Okay, so let's keep going. So, oops, here we go. So I looked up older drivers assessment. So AGS actually is a very nice, this is a very involved figure. This is the only figure I could find from their review. And so I highlighted kind of the physical exam components, but there's a nice guide. If you are American Geriatric Society member, it is free. Otherwise, this is the book. It was last updated in 2019. And it goes through components of a driving history, most of which we covered, right? Has he self-restricted driving? Is driving at night a concern? Have there been accidents, tickets, near misses? Have other family members been concerned about driving? Things like that. Even getting into if a family member has gotten into the car with them, what are they experiencing? Are they having trouble with the pedals? Are they stopping at green lights? Are they, having trouble with signaling? Things like that. Son denied kind of any of that. Although he had not been in the car with the patient either. The individual was having IEDL impairment, so more IEDL impairment is associated with greater driving risk. Medication review, which we did, so he was on I think a Coreg and an anticoagulant and some Lasix, but did not have uncontrolled heart failure symptoms. Visual acuity, so acuity fields, right? Your visual fields, right? So and then also contrast, which I had not thought of. Cognition, so MoCA is in there, but trails and clock draw specifically. So we had some smart folks on today doing those. Motor and sensory proprioception for pedal discrimination is important. Range of motion for neck and shoulders in particular, right? So you can make sure that you have blind spots and can see. Extremity range of motion and functional range of motion, they basically getting in and out of the car safely. And then gait speed and balance are actually also indicative of driving safety. So get up and go and gait speed. So, there are some things additionally that we can add. I think a lot of these we think about, but thinking about them specifically for driving assessment, I thought was kind of a helpful review for me. And what happened to this guy next? So he had normal, kind of went through kind of some of this, maybe not all of it. Normal vital signs. He didn't have any other cardiac symptoms on review of systems that were concerning, or didn't have any physical exam findings suggest uncontrolled disease. He was wearing his hearing aids, had normal corrected vision with his glasses on, had normal visual field testing. He could actually rise without assistance, but using his arms from a chair, had full range of motion of his neck and extremities. His neuro exam was normal, except that he did have decreased sensation, monofilament testing on his feet. His gait was slow, so he could rise, but he was slower with the walker, but was steady. We redid the MoCA again because it had been about a year and it was the same, 23. No sedating medications. He wasn't drinking. I asked about that as well. And then he kind of nicely tied it up for me. He said, I'll just go get a driving test. If you're concerned about it, I'll go get a driving test. And he went and repeated the driving test and the written test and passed it at the DMV. So the state of Oklahoma says he can drive. And he did, though, agree to, come back and let us kind of reassess annually. I will tell you, this case is about 3 years old, and this patient's now 88, and he is no longer driving. So over time, he became more frail, his cognition worsened, and he and his son sort of decided to pull back on the driving. But I thought it was a good case. But hey, Lee, I think I'm so glad that your case got wrapped up when I saw the bow, but what if it's more complicated, right? We've all, thought about had those patients or thinking about those patients. And so I thought kind of reviewing what resources are out there. So the NIA actually has a great kind of driving page that people can access that actually links to a lot of these additional resources, which is nice. So sort of one-stop shopping. The National Highway Traffic Safety Association also has it, and they have a self-assessment if the individual is willing to do that or walk through it with a caregiver. Driving rehab specialist, right? So somebody brought that up. The database, there's an American Occupational Therapy database. It's not totally complete. Like, I actually looked at it for Oklahoma, and I know we have one in Oklahoma City that's not listed on here, but it is a place to start to try to figure out. I looked up Georgia, and Emory has a bunch nearby. And then there were more. You guys had more, so I was jealous. So that's another place to do. And the other thing about OT evaluation, it's not just about driver safety, like yes or no, should you drive, but also about fitting the car, right? About modifications to the vehicle that may allow someone independence for longer, right? Because we don't actually want to leave them in people's independence before we need to. AAA also has the road-wise driver courses. Those may cost depending on the AAA in the area and the state. And then CarFit is another one. I went onto the website. They used to have more in-person stuff. A lot of it is now virtual, but I think there's still value. And this is about how you can fit the car out or edit or change the car to allow an individual to drive for longer. And then if the individual really can't drive anymore, what are some other transportation resources? So Rides in Sight, this is a nonprofit organization, independent transportation network that's dedicated to older adult driving safety and transportation needs. And they have resources. Elder Care Locator is another one. And then if somebody can do public transportation or mobile apps, either from both a mobility and a cognitive situation, what we see is sometimes they can't, right? So that ends up being less useful. Those are options. Medical ride services. So state Medicaid programs will often have medical ride services, as will Area Agency on Aging. And then thinking about grocery delivery and meal delivery for caregivers and suggesting that as a way to make sure people have some independence in ordering the things that they want and being able to get the things they want, even if they can't go out and get them. So I think that is kind of my last slide here. What we covered, taper tools for high-risk meds, hearing loss, connection between hearing loss and dementia, lower cost hearing aid options, and older drivers assessment and transportation resources for people. And with that, I will end. I just want to say a big thank you to this is our team in Oklahoma for our GWEP. They are amazing individuals who make all of our programming possible. And with that, I will stop and take any questions. And then this is the evaluation piece.
Lee, thanks so much. That was awesome. We really appreciate you. And if you are still, if you still have your smartphone out, appreciate you going ahead and going to the GMN Insights review. I'll also put this clickable link in the chat for you. Lee, deeply appreciative. That was a lot of fun, just as you said it would be. So thank you so much. All right, for folks who thank you, Pam, for Pam Vora. For folks who have to sign off, that's great. Otherwise, we just may hang out for a couple of minutes just to chat and stay in touch. So thanks everybody for signing up, and we'll go ahead and stop the recording. Thanks everybody, and if you want to stay for a couple of minutes, feel free.
Sure. Thanks for having me. It's fun. It's nice to see.
We've got friends here, so please feel free to come off mute and say hello, because it's one big community, and really glad that Lee could join us across some time zones to spend some time. Carolyn's working on coming off mute. See her thinking.
I've been reading her body language throughout the talk. It's been helpful. But like, she's like, you find somebody in the audience, you kind of talk to them. You're my person.
There you go, Carolyn. I think you're off mute.
I am. Yeah, we were in the same room, so we were kind of managing our sound. We've Zoom sound management strategies in here in the shared little office. Anyway, just saying, hey, great job.
Thanks. Nice to see you.
Yeah, same. Hey, you did see that other piece about the academy for the if you have NPs or PAs in the system, let us know. I think we're gonna probably end up closing that by the end of the month. So I just wanted to, even if they're just interested.
Yeah, and is that all outpatient focused? Yeah.
It is primarily outpatient focused, definitely.
Because that's another thing that's come across my desk recently, my inbox recently, is inpatient training for advanced practice providers and dementia. So
I mean, there's a heavy focus on kind of understanding like deep dive around different pathologies. There's a couple sessions on behavioral symptoms and sticky situations. There's stuff on like caregiver sort of management and referrals as well. So I wouldn't say it's unrelated.
Yeah.
And it's a small session. Like the cohort is capped at 12 people, and there's individual coaching.
That's nice. That's really
good.
Good.
Right. So I think like each person has kind of their own goals. There are some people who are like in specialty practices, some people who are in primary care and like want to be doing CAVs or cognitive assessment visits, and want to feel a little more comfortable doing that stuff too. So
thank you. I think I will look at it. Sounds really, really good.
I think so. The faculty person is pretty amazing. She is seeing patients right now, or she'll probably be joining us.
All right, good people. Lee, thanks again. It was really awesome. It was great to see you, and it was a lot of fun. Thanks for bringing cases. I know that case-based presentations are a real fave for the group, and so appreciate you.
Thanks for having me.
All right,
so much, Lee. Bye-bye.
See ya.
Bye.